So welcome everyone to the Coronary Artery Disease Clinical Council Roundtable discussion on coronary artery disease. My name is Dr. Rajeev Narayen. I'm an interventional cardiologist at Nuvance Health, where I'm primarily at the Vassar Brothers Medical Center campus in Poughkeepsie. This is a joint conference between our two campuses and is brought to you by the Heart and Vascular Institute of Nuvance Health. Today we have with us several prominent members of our both cardiology, interventional cardiology, as well as our cardiothoracic surgery departments. Aside from myself from interventional cardiology, we are joined by Dr. Arshad Yekta, our wonderful and esteemed cardiologist from Nuvance Health, mainly at the Connecticut campus. We also have David Tecchio, one of our lead physician assistants from the cardiothoracic surgery department, Dr. Alon Aharon, one of our cardiothoracic surgeons from Nuvance Health, Vassar Brothers Medical Center, and Siobhan Meyer, one of our nurse practitioners from the Nuvance Health Connecticut campuses. And we're here to bring to you a little bit of a discussion on coronary artery disease. And we meant this to be a roundtable format so we can discuss some of the details and have everyone have a little bit of an understanding of where we sit with coronary artery disease in the year 2021. So I'll start by asking some questions. The first one to you, Siobhan, if you can describe perhaps a little bit about what is coronary artery disease and how common this condition is, as well as how frequently you see this in your practice, that would be great.
So coronary artery disease is any condition that causes a decreased blood supply to the heart muscle. Over time, coronary arteries, you can build up cholesterol and plaque. It sticks to the inside of the blood vessel. So that's the most common cause of coronary artery disease by far, is the buildup of these coronary artery atherosclerotic plaques. And then over time, the blood vessels become narrow, and the blood vessels can also form clots inside them because the plaques are in there. And this can block the blood flow to the heart muscle, preventing the blood supply from getting to the heart muscle and supplying the necessary oxygen and nutrients that's needed. So if the blood supply significantly decreases in the coronary arteries and eventually becomes blocked, you can have heart damage and even a heart attack.
Well, that's a great description, Siobhan. Could you give us a little bit of an understanding of some of the risk factors that that can lead to coronary artery disease development?
Sure. So there's many risk factors. One risk factor, a big one, is hypertension. That's often known as the silent killer because you don't have symptoms unless your blood pressure becomes very high. But over time, the high pressure running through your blood vessels causes thickening of the arteries and inflammation that makes the plaque more likely to stick to it. Another one is having abnormal cholesterol levels, and this could be either high levels of bad cholesterol or low levels of the good numbers, the good cholesterol that you should have. So it's important to know your full cholesterol panel. Diabetes is another one. This is a big one. There's a very close link between coronary artery disease and diabetes. And many people with diabetes actually end up dying from coronary artery disease. Smoking is another huge one. Smoking damages the inside of the blood vessels, making the walls of the blood vessels more likely to have these plaques form inside. Being obese or overweight, those are risk factors, as well as having a sedentary lifestyle. Other risk factors include advancing age. So as we get older, our blood vessels become a little bit thickened and less elastic. Men, it's more common for men to have coronary artery disease, except for women who are postmenopausal. Women after menopause have about the same risk as men. Also having a history of premature coronary artery disease in your family. This would be a first-degree relative, either a mother, father, sister, or brother that has coronary artery disease at a young age. So that would be for a man less than age 55, and for a woman, it would be less than age 65. In addition to that, there are some risk factors that are specific to women. So women, if you have a history of having preeclampsia, gestational diabetes, or having a low birth weight baby, this can put you at increased risk. And there's also risk enhancing factors as well, such as chronic kidney disease and some chronic inflammatory conditions like rheumatoid arthritis and lupus, and there are others.
Thank you so much. Dr. Yekta, as a cardiologist who's extremely well versed in the treatment of coronary artery disease, can you run down what are some of the signs and symptoms which may prompt you to discuss evaluation for coronary artery disease in some of these patients and how you might think about testing for this?
I'm sure. So, ultimately coronary disease can manifest in many different ways for individuals. Obviously, the differentiation that one needs to make is if you're having an acute issue or a chronic issue. So how long have these symptoms been going on for and what the pattern is. So in terms of just symptoms, the most typical symptom that people will describe, and you'll hear this, from your friends and things like that, is chest discomfort or chest pressure. In particular, if there's radiation to the jaw, for example, or to the arms or to the back or things like that, can be a symptom of coronary disease. However, a lot of people, in particular, women, would never have chest discomfort as a symptom. So shortness of breath can also be a symptom of coronary disease. Just noticing that you're getting more tired or shorter breath with activity or doing the same kind of activity you were doing before, but just feel like you can't do that any further. Fatigue as well. Just feeling like you don't have the energy to do something, maybe a manifestation of coronary disease. But the most important thing to understand is that there's no specific symptom which is identifiable to everybody. So you have to really kind of understand that your body oftentimes has a way of telling you that something is not quite right. So my suggestion is if you just feel uneasy in terms of activity levels, you're getting shorter breath, chest discomfort, fatigue, those are all symptoms that may prompt attention to a provider to seek further evaluation, in particular for coronary disease. And just going back to, well, what is coronary disease and how can it present and what the acuity of it is? Well, we have to understand that there are issues that need to be addressed on an urgent manner, and there are times where it can be addressed on a more elective manner. So, for example, if your symptoms are crescendo or increasing rapidly, that's something that I would suggest that you might want to contact somebody or even just bypass and go into the emergency room for further evaluation. Or if you're having symptoms that are happening at rest and they're accelerating, or symptoms with minimal activity, I think that all seeks prompt medical attention at that time. If symptoms are happening with moderate activity or greater and are fairly stable, I think those symptoms can oftentimes be evaluated on a more elective office-based manner.
That was great. And, I can tell you that I've had several times where I've read, articles in the New York Times, and I know that many of our patients are reading some of these same articles about being exposed to, say, a stress test. And I know that it's been all over the place. And in this modern era, we have the question of, should people get routine stress tests? What's the role of nuclear stress tests? And I know we could have a whole conference probably just on stress testing alone, but if you can maybe give us a little bit of your perspective as someone who's so up to date in the literature, where do you see the role of stress testing in 2021 and ischemia and life after ischemia?
Sure. So first of all, in terms of stress testing, I think stress testing is really reserved for people who if they have normal heart function and no significant arrhythmias, is really for individuals who have symptoms. So I'm not a proponent of asymptomatic stress testing on people that come in just because they have risk factors. I don't think that adds much value. But it is definitely useful as a risk stratification tool still. And I think even after the ischemia trial did come out last year, which was a study that demonstrated that in individuals who had abnormal stress tests, in particular intermediate to high risk abnormal stress tests, that one can actually take an approach of either medical therapy versus invasive approach as a first-line therapy. There was no real significant difference between both arms in terms of cardiac event rates like myocardial infarction and death. Even though symptom relief was better in the invasive arm, it just means that you can take either approach to start off with. Ultimately, in terms of nuclear stress testing, we have decades worth of data going back that clearly denotes that there is prognostic data for this. And I think, when you look at it, if you still quantify the degree of ischemia, it helps us as clinicians kind of risk stratify you in terms of your medical therapy. It also gives us an idea of what your true functional capacity is in an objective measure. Obviously people are at home and you have a certain idea of how you're doing on a functional basis, but how do you compare yourself to others in your age group for your gender match controls? And I think stress testing offers irreplaceable data in that regard. So I still think even in terms of the ischemia trial, I think it's still very useful. In particular, you also have to understand that ischemia they also ruled out patients with left main coronary disease. So if you have symptoms, you still want to make sure that you don't have a high risk stress test, because if you do, you still need to understand you may have to get a CAT scan or something along those lines, even if you do elect for medical therapy.
I think you've outlined a really important, critical point here, which is so eloquently described by you here, which is that when we talk about people and the general data, its applicability towards any one person has to be so individualized. And I think that's where that discussion between a cardiologist and the cardiac team, as well as with that person, can really come into distinguishing who would benefit by certain types of testing and who would not. So I think having the blanket statements that stress testing no longer found to be useful probably doesn't have a great headline. And I think that sometimes it catches people's eye, but I think when you really delve into the details, what's probably a more accurate way of saying it is that stress testing is probably not useful for some people, but that in fact it could be very useful with the right tools and the right hands for helping us to distinguish things. So now let's just say that you've made the decision after evaluating someone that they need to have a cardiac catheterization. Maybe can you run down a little bit about what that experience might look like for patients, radial versus femoral, what the stent day might look like, and how things might look from there?
Sure. So, the biggest fear people have is obviously going through an invasive procedure. In understanding the cardiac catheterization is a minimally invasive procedure. So there are traditionally two approaches that we use, and for the most part here at Nuvance, we are using a radial approach, but also femoral approaches. So putting a small needle into the artery of your wrist, which is called the radial artery, or a small needle going into the artery of your groin area called the femoral artery. And then through that, we're able to pass very small catheters, which are about 2 millimeters in size, that go up through your blood vessels and to your heart, where we're able to use contrast and x-rays to kind of look at the arteries and assess exact percentages. So we're able to look at percentage stenoses and the presence of calcification as well. And also, it gives you a lot more information, but when you're able to actually see the blockages, I think there's many factors that also help us in deciding, well, is this a higher risk blockage or not? And we use many modalities like imaging as well to help us denote that. But in terms of the procedure itself, it doesn't tend to be a very painful procedure. Most people, you feel lidocaine, we'll give you some lidocaine at that area, but after that, really, most people feel fine. They don't really feel too much more pain afterwards. You don't have nerve ending inside your arteries or anything like that, so pain is very minor. In the procedure itself, just by doing a diagnostic angiogram is a very low risk procedure. The rate of complications is well under 1%. We're talking about on the order of 0.1 to 0.2% for a major complication to happen. The procedure time itself, anywhere between 20 minutes to 40 minutes for a routine diagnostic angiogram. And most people are pretty comfortable because we do give patients some little sedation, but we don't put you to sleep. Oftentimes when people ask, are you knocked out? And my answer to them is this: this is not a very uncomfortable procedure. You don't need to be knocked out. And in fact, I'm actually speaking with most of my patients as I'm doing the procedure, letting them know what I'm doing and what I'm seeing. And I think most people are happy to see that. So in terms of, so what do we find? Obviously we can find blockages, and then we have to make a really important, objective, thought-based approach to every patient as to who needs an intervention, who doesn't need an intervention. I think that's where the clinical data is so useful, just understanding, who the patient is, what they're trying to accomplish with this, what symptoms do they have before, and what medical therapy they're already on. And only then do I feel like I can make a thoughtful approach as to who needs a stent and who doesn't need a stent.
And as we transition out of that discussion, which I think is so important, what are some of the things that would because we've heard so much about the heart team approach, and maybe can you explain a little bit about what that means and what makes you reach out to, say, one of our surgical colleagues, and what are those things that sort of makes that decision, and how do you have that communication?
Sure. So whenever we do an angiogram, we're able to look at the complexity of lesions. So number one, we can determine how many blockages you have, and number two as well, from an interventional cardiology approach, how easy is it to fix these? Do they have branches coming off the lesions? Are they in main arteries like the left main coronary artery? Are they long blockages? So, and then we're able to calculate different scores like a syntax score to help decide, do these patients, are they better suited with bypass surgery, or are they better suited with coronary stenting? And I think if there's any a time where there's ever an intermediate risk patient, I think it's always useful for us to kind of consult with our colleagues, because the most important thing from our end is making sure we deliver the right approach, which is going to provide symptom-free living for the longest period of time. So and from our, again, listen, from an interventionalist approach, we can stent a lot of lesions, but I think the most important thing is understanding what is right for the patient. So we have a very low threshold for involving our CT surgeons. And again, if we decide not to do surgery, the risk of a diagnostic angiogram is relatively low. So we can always bring that patient back soon thereafter if they elected not to do surgery and fix what we need to do by an interventional approach. But it's better to have that option than it is to fix something and not give that option to the patient.
Thank you very much. So reaching out to our surgical colleagues, Dr. Aharon, as one of our esteemed heart surgeons, Nuvance, can you tell us a little bit about where you see the role of PCI versus surgery is? Who do you potentially see maybe better suited towards surgical therapy versus interventional therapy versus even medical therapy?
Very good and relevant question. So class 1 indications for surgery include left main disease, 3 vessel disease, 2 vessel disease with proximal LAD lesions. And 2A is essentially 2 vessel disease without proximal LAD stenosis. So really, there's a lot of nuances and gray area, but in 2 vessel disease where a mammary would be beneficial due to its longevity, I think surgery is an option, the primary option. But unfortunately, or fortunately, medicine is an art, and many patients fall into the gray zone. I'll give you a couple of examples. Rajeev and I had a patient in common, 90-year-old, very complex proximal disease, frail, but doable. STS risk was 6 or 7, so moderate. 8 and higher is we would consider high. And very, very complex proximal PCI. So we ended up operating on the patient. Patient did well. We've had other patients. There's a patient that I think Rajeev is going to hear about. That's an 80-year-old, left upper lobe lung cancer, frail, didn't want to do a lobectomy, I think, because of frailty. PO2 on room air is about 80, 85. Patient walks, but could easily end up with a trach. Creatinine is 2.5, so stage 4 kidney disease, could easily end up on dialysis. Either way, family would like a less invasive approach. So we are offering that patient surgery if PCI is not a technical option due to occlusion of the LAD to its mid portion and the proximal circuit occlusion. So we're fortunate that our cardiologists are skilled in CTOs and complex cases and do Impella-assisted PCI. So it broadens our ability to offer these patients some sort of revascularization. But in general, if you look at patients, each one is individual, as an individual, as they should be. Patients who have a difficult time rehabbing with a sternotomy, 4 to 7 days in the hospital, rehab. I think that's really important. Their frailty index. And I think what we've learned from TAVR is that if patients are frail, even moderately frail, then potentially a catheter-based approach is better.
I think, Dr. Aharon, I think you've really outlined a very important point also that I want to reemphasize, and so well said, which is that, the American College of Cardiology and the American Heart Association has made a very strong recommendation that heart teams be employed for the use across the spectrum of care for patients with heart diseases. And I think what we've done at Nuvance is something that was so forward, even before that recommendation occurred. One of the things that we've done throughout our systems is that communication, the open communication between all members of the cardiology team, from our advanced practitioners to our cardiologists, our interventionalists, our imaging doctors, and our heart surgery team, that we collaborate in a very integrated manner in order to deliver that optimal healthcare to our patients. And I think one of the ways we do that is by that open discussion. So, I know we've participated on calls every week on Wednesday mornings and Friday mornings where we discuss patients who have complex conditions where both therapies, interventions and surgery and medication therapies can be employed, and we look to seek what combination of those treatments can optimally deliver care. But one of the questions I think that comes up all the time is that I get patients coming to me after they've met with the surgeon and they say, I'm just too old for surgery. What do you tell that patient? Is there something that's too old for surgery? Or, can you tell me a little bit about that patient who's afraid to say, I don't want my chest cracked open? What do you tell that patient?
Well, I mean, you have to go by data and not your individual data. So if you're looking at an age, first of all, the STS risk factor analysis underestimates morbidity and mortality with respect to age, and that's clear. And also, by the way, obesity. But I think that age is physiologic. It's not really numeric. And if a patient is 90 and is functional and can withstand sternotomy, which is an incision that's generally better tolerated than a thoracotomy and sometimes better than a hernia repair, which can be very painful. I think that patient should be offered surgery. So what we try to do is assess whether the patient can tolerate the rehabilitation. I think acutely, we're very good at getting patients out of the hospital alive, but is that patient going to do well in the long run with a 2-month rehab? And that's elderly. And we have patients that are 50 that really are physiologically 90 and vice versa. So it really has to be tailored, but I think age, I try to dispel when I speak to the family, age as a significant factor in their decision.
Thank you.
I just numeric age, physiologic age is a different story.
That's a great point. I think that separation between the number of age and how someone is really as a medical age is so complex. I mean, you can have people who are very young with a lot of medical problems who may not benefit from surgery. You can also have people who are who are older by number, but medically speaking would do very, very well with surgery. And I think that's part of where that discussion between all the members of the team really makes a difference. That was well said. So Dave, you're an integral member of our surgical service. I'm sure that you're constantly faced with patients who have apprehension about getting their chest cut open and probably have vivid images of a gory scene. Tell us how you would describe what the real surgical experience looks like, and that concern about pain and other things about surgery. How do you deal with that?
Yeah, I mean, I think that's a great question. And, having open heart surgery in and of itself is usually, a jaw dropping, when you tell the patient that, you're recommending open heart surgery. And certainly the surgical approach for coronary artery bypass surgery is almost exclusively a median sternotomy. There's other surgical approaches for different heart operations, but for coronary artery bypass surgery, you make an incision through the breastbone. And a lot of people use the term cracking the chest. We certainly don't use that term because the surgical incision that we make is very precise. It's very safe procedure. And during the operation, we take great care of the tissue to give that bone every opportunity to heal. And at the end of the operation, we actually fix that fracture that essentially we created with wire or cable, and that helps keep that breastbone together. So that you'll find that a lot of times that incision is much better tolerated because there's less movement because of the rigidity of the sternal cables that we put in to hold that in place. A lot of times you'll have an abdominal operation that causes a lot more pain than the incision we make for bypass surgery.
I think that's a really well put statement. I think I get a lot of people you coining the term cracking the chest open, but actually, this is not a lobster that you're cracking. This is a carefully divided, skillfully divided incision that you guys are making with the most advanced tools possible, with an incredible wealth of experience. And just like you just so accurately mentioned, when you're able to put that back together at the end result is actually a really well-healed incision, and people tend to do really, really well from this. And having seen the results of your labor afterwards, I know people tend to feel really well, and actually the pain seems to be really well managed by your service. Maybe you can speak to a little bit of that that management and that operative time frame, how you guys manage discomfort, and talked a little bit about that.
Sure, absolutely. I mean, certainly post-operative pain is something that after any operation is a part of the management. But I will say that after heart surgery, pain is not generally the predominant symptom. About a decade ago, we used to make a really long incision on the leg, and that was predominantly the biggest source of pain for our patients. But now we take the vein out endoscopically with a very small incision. And so really the most symptoms that the patients have after surgery, certainly they have some chest discomfort that we manage very well with both opioid and non-opioid pain medications. But also most of our patients are fatigued and just like low energy that gets better over time. But pain, maybe less than 5% of the patients, we might sometimes need a pain control device that the patient can control to help eradicate some of their discomfort. But for the most part, pain is not an issue after surgery.
And I think I echo that sentiment. You guys do a really great job of management of that, and that's very well done. Just in the interest of time, we have a few things we wanted to cover for people, I think, that are really important. Siobhan, maybe you can comment a little bit about the importance of cardiac rehabilitation. I think Dave alluded to the fact that people feel fatigued after surgery. I know that Dr. Yekta and I have patients after interventional procedures that can probably benefit. For whom do you recommend cardiac rehabilitation? How is that used?
So cardiac rehabilitation is actually recommended for anybody that has had a heart attack, that's had coronary artery stents placed, also patients that have undergone bypass surgery and other heart problems or heart procedures. It helps the patient improve their quality of life, and it also can help prevent future events in the long run. Patients are monitored with heart monitors and trained professionals while they resume physical activity. And they also are able to avail of a lot of education about lifestyle modifications. And these are modifications, changes that patients can make to help prevent further events from happening. So controlling your blood pressure, your cholesterol, your blood sugar, your weight. So you get education about a healthy diet, a heart healthy diet that emphasizes fruits, vegetables, nuts, grains, lean proteins and fish, limiting your salt, and also strategies as to ways to quit smoking and be successful. Also, I believe coping with stress, and really they take the whole person into consideration and help them through the recovery and focus on long-term benefit.
That's a great point. And speaking a little to the long-term, Dr. Yekta, obviously you have a lot of patients who've had either a procedure interventionally or surgically, and they come to you. What are some of the things that they should be calling you about? And how do you manage some of the post-procedural course, whether it be medications or testing for concomitant other diseases that seem to come along for the ride with coronary artery disease?
Sure. So just in terms of, what should people expect after a procedure and intervention? For the most part, the recovery process is relatively short, especially if we're using access sites like the radial artery. Oftentimes you have a pressure bracelet on your arm for 1 to 3 hours, but people are able to walk almost immediately thereafter with little to no issues. And even if you have a femoral access, nowadays what we're using closure devices in patients, which improves your ability to walk at a shorter period of time. So you don't, back in the days you may have heard stories of people having sandbags and things like that put onto their groin. We don't use that anymore. So now we put a little suture, a little plug into the artery, which seals the artery as well. So even within 2 hours, people are oftentimes able to ambulate, even after femoral access technique. So when you do go home, if you have a stent put in, we always make sure that you're on the right medications, because it's not just about the medication you need for your stent, but it's also about the medications you need overall and how to prevent this from happening. So making sure that you're taking an aspirin, making sure you're taking a cholesterol medication, and that your blood pressure is reasonably well controlled, and you're taking whatever else you need to do, your appropriate diabetes medications as well. But if you do have a stent put in, keep in mind that we oftentimes will send you home with another blood thinner, what we call a second antiplatelet agent. And that can range in between 6 to 12 months of duration. But that's why you need to follow up with your cardiologist soon thereafter. You really need to go over the game plan, what you're going to be expecting in your short to long-term plan, making sure you do get involved in cardiac rehab. In terms of your immediate care post-op, post-cast when you go home, I tell people have a low threshold. If there's something which is not quite right, give us a call. We can always help manage that. If needs be, we can always come back and have you come back into the office or hospital to see you. But if you're having bleeding, or if you're having coolness in your leg below the catheter site, if you're having fevers, if the incision becomes red or it starts to drain anything, we do recommend that you come back in so we can evaluate you further. In terms of concomitant issues, this is actually a very important point, Rajeev, is that we do know that in individuals who have coronary artery disease, there's a high prevalence of concomitant disease in another vascular bed, i.e. the cerebral circulation or the peripheral arterial circulation. So studies have shown anywhere between, if a patient has CAD, that they may have, an incidence of 26 to almost 42% of having a blockage in the carotid arteries or a blockage in the leg arteries or somewhere else. So I think that's important to understand that those also have to be evaluated. And the best way to evaluate that was with a good, thorough physical examination. Just, making sure that the doctor checks your pulses, listens to your carotid arteries, and things like that, assesses your symptomatology. I think having a good clinical exam is better than just kind of throwing, here's get all these tests done, because I think the testing has to be done on a clinical basis. We have to have that objective data on exam and by history to know who should we test. Again, according to ischemia trial, like you said before, not every test is appropriate for everybody. You really need to tailor a patient's care to them and decide what needs to be done.
I think that point about coronary artery disease really being more of a systemic disease, I think is something that's so important, because we're really not just talking about an isolated system. Even though when we talk about coronary arteries, we're talking about the heart arteries. Understanding that arteries go all over the body, and the fact that we have it in so many systems is critical. So I think that was really well said. Dr. Aharon, when we're talking about people who are after surgery, what are your recommendations for returning to work or driving after having bypass surgery? What recommendations can you give in that regard?
We see the patients at 2 weeks. Patient gets a chest X-ray, examined. They can drive at 3 weeks. And depending on what kind of work they do, if they do physical work, they shouldn't lift anything heavier than the phone book for 2 months, which, for a construction worker who makes his living doing that, may be very difficult and really may hurt him economically. So 2 months or greater for the sternum to heal, 3 weeks to drive, and patients really can go back to work depending upon their job. We've had bank managers call from the, from the ICU, and we've had construction workers off 3 months. So it really depends. And that also has to be modified. Some of our patients, unfortunately, are debilitated, walk with walkers. That's a whole nother issue in terms of sternotomy healing, irrespective of age. So, but really they can drive at 3 weeks, and at 2 months, they can pretty much do whatever they want.
That's great. And Dave, what resources can you recommend for patients and people who are interested in learning a little bit more about cardiology and cardiovascular surgery at Nuvance Health that they can reach out to?
Absolutely. I mean, Nuvance Health, we're a 7-hospital health system. We have over 2,600 physicians and advanced practice providers that our medical practice and hospitals are affiliated with. The Heart and Vascular Institute encompasses the best cardiologists, cardiac surgeons, vascular surgeons, really electrophysiologists, interventional cardiologists in the area. And to learn more, you can just go to www.nuvancehealth.org. We also have a social media network. We have a Facebook page, which is videos like this throughout that page. There's a lot of information for the public to learn. And we can also follow us on Twitter.
Thank you, Dave. And I really want to thank our panel today, Dr. Yekta, Dave, Siobhan, Dr. Aaron. I think the point to really drive home today about coronary artery disease is that this is it's a devastating condition that can be controlled, managed, diagnosed appropriately, and treated appropriately with excellent recovery, but needs to be done in the context of a team-based approach that I think that we can deliver very well here at Nuvance Health through our Heart and Vascular Institute. For further questions, as Dave has indicated, please refer to some of our websites as well as our social media accounts, and we look forward to caring for you and your family. All right, take care.